and good morning, everybody. And it's a pleasure to be back with you again. I hope you've been enjoying not only the educational platform, but also Kiowa and South Carolina. It looks like the weather has cooperated a little bit more. Today, for this talk, and we can continue into tomorrow's session.
Let me switch on you.
What do you need?
Dr. Pijak must have you. Let's try this one.
That's what I was using. The same thing.
Same place? Good.
All right. Let's try this again. Is that any better?
Yes, thank you.
If Randy says it's better, then it's better. The people in the back row hear me adequately, because sometimes I do. I've been sitting in the back just to test that side of the back of the room. I was always a back row kid anyway, so it's sort of like my natural environment. Today, we're going to continue the theme regarding obviously very, very common disorders, but how do they specifically apply to our female patient? Of course, gender differences, particularly associated with women. But also, men are important as well. So when there are similarities, we're going to discuss both as well. However, before we go on, I'd like to recap where we were Monday on the lecture that we had in terms of controversies of hypertension. And the discussion predominantly revolved around the hypertension guidelines, where have we been, where are we, and where are we going. And these are some of my thoughts during the early evening hours since that lecture, in terms of just sort of a recap where we've been. And it's also going to help us with the talk this morning as well. Well, we started with these times are changing. Again, I'm a 60s kid, so Dylan is very close to my heart, if not my brain. And thank God I disconnected him from my brain at the time, but obviously now a Nobel laureate, and I'm jealous as heck. The clinical implications of SPRINT we discussed. A very substantial study, obviously well done. Asked a formative question about intensive blood pressure lowering versus standard blood pressure lowering, and the results were positive, as you remember, but it's still vigorously debated versus the methodology. They were high-risk patients, they were subsets of individuals, and are they applicable to our general practice, not only the patient profile, but how that study was conducted. And that is continually being vigorously debated. Actually, yesterday there was another debate that I saw that hit the lay press, particularly from our European colleagues that are not as enamored with the SPRINT trial and the results as some of us, or we are, obviously in our country, in the States, and has not made it into their guidelines and their deliberations as much, but I believe it really will in our guideline committee that's deliberating right now from the American Heart Association and the American College of Cardiology, our colleagues of both of those organizations. The new guidelines may significantly change the way we practice, not the treatment of hypertension per se, but when we treat, who we treat, and when do we end the journey. And I believe that there will be some substantial changes along those lines, one of which might be. And I say might because they're not going to come out into the late fall. And there's deliberations, there's groups evaluating the guidelines, and they still can be changed. But pre-hypertension may now become the new hypertension. And what does that mean? That means that the blood pressures that we now consider pre-hypertensive, although we show that they have increased morbidity and mortality, we don't have evidence-based medicine to treat those individuals. Well, SPRINT may be extended into this category of individuals, and pre-hypertension may become the new hypertension. And again, we may be looking at not only just lowering below a number, like today, it's in our general population, we treat patients with greater than 140/90. So when do we end the journey? When it's less than 140/90. Well, that could be 139/89, etc. On the other hand, I think we're going to get more specific targets or intention to treat targets from these guidelines, perhaps 130/80 in the general population, and specifically some high-risk clinical subsets. Don't know whether it's going to be lower than that. Of course, SPRINT, the target was 120/80, but I think there's going to be a compromise regarding the committee in terms of that 120/80, because remember the methodology differences in SPRINT were oscillometric, and they were non-observed blood pressures. They were taken by a machine in a quiet room, and those blood pressures may be significantly lower than in the clinical trials in the past that we formulated our evidence-based medicine today. So we have a choice. We can either take all the blood pressures with that methodology, which many are advocating is the actual proper way to take blood pressures, but that's not going to happen overnight, even if we ever could do it at all. So there's going to possibly be some sort of a compromise, and I believe a good compromise is going to be 130/80. But we'll see. Stay tuned. I think it's September 28th that the guidelines are targeted to come out. Specifically, the date has already been decided. It'll be at the American Heart Association Council meetings as well. But you know, who knows? That could change. Well, let's move on. We're actually doing a good job regarding cardiovascular disease deaths in this country, as our other colleagues are doing in Europe, and even in certain countries in South America. But globally, of course, the disease burden of cardiovascular disease is only increasing, and it's increasing rapidly. So it's a global issue. It's getting worse. As a national issue, we're doing much better, as you can see. But clearly, we're not there. You always have a long way to go when you go from here to here. We'll never probably close this gap entirely, but we still have a ways to go. That's in our general population, of course. But what about men versus women? Are women more complicated than men? Just ask me. I have 4 kids, 2 males and 2 females. My females are clearly the lower panel versus all the knobs, gizzards, and buzzards than my guys in the event. And in many ways, they are more complicated. Females are more complicated than males for many different reasons, and we've been visiting them throughout this symposium, not only hormonally, et cetera, stress, environmental roles, gender roles, et cetera. There's extraordinary differences, not only genetic differences, but psychosocial differences that we've already heard from your colleagues. What about life expectancy regarding race and gender? Are there differences in life expectancy? Well, it's been going up for everybody. That's the good news. But you can see, white females, it's increasing, and it's now approaching 85 years of age. Black females are also going up. However, there's the good news. As we've all known, females have longer life expectancies than be it a Caucasian male or a black male as well. That's the good news. But there's still significant differences, and there's significant disease burdens within the female population that we should be cognizant of and address, particularly as it relates to hypertension as well. So what's the leading cause of death in women? Obviously, as a person that's dedicated my life to hypertension, vascular disease, and cardiovascular disease in general, I always hear about breast cancer. I always hear about lung cancer, et cetera, but obviously we know in our daily clinical practices, in our daily lives, that cardiovascular disease, coronary heart disease, and stroke far outnumber the other entities, lung cancer and breast cancer. Not that these are not important, of course, but it's interesting the publicity that some disease states get, appropriately as a matter of fact. However, coronary heart disease, stroke-related vascular disease deaths in women far outweigh the other. So you got to put your money in 1 or 2 places. Here's where you would put your money. Well, how are we doing? If that's still the leading cause of death in women as it is in men, how are we doing with it? And as you can see, we've done a really good job in males. Interestingly enough, when I looked at this data from the American Heart Association most recently, there's been a steady decrease in cardiovascular disease mortality in males. But interestingly enough, not so in females. You can say lately there is, but if you took this entire curve and you did some fancy statistics over the duration of about 20, 30 years, there's actually not been a decline in cardiovascular disease mortality in females, although some would argue that this is probably real, but at this point in time, here's the data, and the data is what the data is. So somehow something's different, something's missing. We may be doing something different with males versus females. Let's explore what they may be. And then how possibly can we do it better? This is death rates in women by age. Again, for very different diseases, as you can see from coronary heart disease, stroke, lung cancer, breast cancer, colon, endometrial cancer, all of which are obviously extraordinarily important, and we've been discussing over the course of the past few days. But look at the rapid rise in age, in coronary heart disease-related deaths, and in stroke-related deaths. And in fact, if you look at by age, while they might go up, the cancer-related illnesses may go up slightly, nothing as dramatic as the cardiovascular disease death rate from coronary heart disease and stroke. And as women are living longer and living longer than men, this is obviously going to be very, very significant. So any effort we make to understanding why, understanding the mechanisms, and then potential treatment, targeted treatment, personalized medicine treatment options for women would have a great benefit, not only to the individual, but our society as well. Well, what about the continuum of cardiovascular disease death rates in women across the ages? We always hear that, well, wait a minute, cardiovascular disease in women is only postmenopausal. They're protected until they enter menopause, and then yes, it goes up, maybe the same slope as in men, but obviously lagging far behind. That's not true. It's partially true. And as you can see here, by age, and these are the death rates of cardiovascular disease amongst women across the ages, yes, similar in men. Cardiovascular disease death is greater as we get older. On the other hand, it's not insignificant. More than 35,000 women will die of cardiovascular disease deaths before the age of 65. Many of those are going to be perimenopausal or even premenopausal. So this is not a menopausal, postmenopausal disease. This is a continuum like everything else that goes up exponentially as we all age, as most diseases do. So what was our traditional paradigm? And I think this is an important shift. At least I was taught not too long ago, hopefully, but every day is another day. Remember the definition of elderly. According to Dr. DiPette, it gets one day longer for every day I live. The traditional paradigm in women was with cardiovascular disease that there was really no risk. It was minimal, or there wasn't any at all, and go on to something else if there's a complaint of chest tightness, etc., maybe some jaw pain, some early fatigue. It's not coronary disease. Maybe it's depression. Maybe it's some other entity. Of course, can't be clearly more wrong. The alternate paradigm that we're hopefully going to be increasingly educating, not only our practicing clinicians, but our population at large, is indeed like any other disease, as in males as well, cardiovascular disease-related morbidity and mortality in women is really a continuum. It's an exponential continuum, but there is no safety zone about this. And we've just got to go, yep, that's the way it is, and move forward. And then I think we're going to be able to change the paradigm, change our approach, change our thinking, and have greater salvage of our female patient from cardiovascular disease burden in general. I put this slide in for Dr. Piesiak because I have paid great homage to endocrinology, and I've paid great homage over my lifetime to diabetes. I am still learning, and I'm still learning, hopefully, on a very brisk learning curve. The diabetic is a very, very special patient, but it's extraordinarily very special in women in terms of cardiovascular disease and cardiovascular disease mortality, as you can see here. Non-diabetic women are here. We've always known that diabetes in general is a cardiovascular disease, as it is an endocrinologic disease and a metabolic disease, of course. But look at the increased risk in our diabetic female population. If you had to have one population to pick, and you're on a desert island, and they say, treat this one population, and you could pick any one population, this would be a population that I would seriously entertain and select, because look at the dramatic disease increase. This is not seen as much as greater in men, probably because the baseline in men is greater. On the other hand, pay particular attention to your diabetic female patient as it relates to cardiovascular disease symptoms, signs, and then obviously diagnoses and treatment. Well, there are gender and non-gender cardiovascular risk factors. We all know the non-gender cardiovascular risk factors. We don't have to deliberate them, but there are gender differences in women that don't pertain or rarely pertain to men, and that is menopause and, of course, birth control pills, particularly in combination with smoking. I'm not telling this audience anything that you don't know, but sometimes it's just good to see it again and to talk about it again and to think about it again. And we'll explore some of this. I've often been taught, and I'm going to try to dispel some myths, that the presentation, the symptoms, if you will, of cardiovascular disease presentation really radically differs between men and women. And the fact is that's not true. They're very, very similar with some slight differences and slight caveats. This is a recent study from the American Journal of Critical Care, Devin and colleagues, that looks at symptoms of coronary artery disease, both in males and females. The females are in purple, the males are in light blue. And as you can see, there's more similarity than there is differences. However, there are three striking symptoms that are significantly different in women than in men. By the way, presentation of chest pain is not different. Although we're taught it's a little bit very typical, et cetera. Yes, that's all true. But actually, when you get down to really analyzing it, it's pretty much the same with certain caveats. But fatigue, shortness of breath, and weakness is, for reasons we do not understand, more common as presenting cardiovascular symptoms in our female patient than our male patient. The problem is they're very nonspecific. And on any given day, I have fatigue, shortness of breath, and weakness. And I don't know if anybody would like to run and put me in a stress test or a stress thaling or percent thal. But nevertheless, though, be cognizant that there are gender differences in symptoms. They're not great, but these are three that I would pay particular attention to. But what about the quality? That was the location and associated symptoms. But what about the quality of the chest pain? I've often been taught the quality is different, that females present slightly different in terms of the quality of the pain, maybe a little more subtle, maybe not as intense, maybe not that elephant squeezing on your chest, etc. But again, same study, again from 2008, and surprising to me, there were really no statistical significant differences in the quality of the pain, and the quality as to pressure, tightness, heaviness, dull, etc., sharp differences between men versus women. How about the location of the chest pain? And the answer is yes, there are. There are gender differences in the presentation of the location of the chest pain. As you can see, females will present more with neck pain and more with jaw pain, about twice as often than men. But central chest pressure, left chest, left arm, upper back, etc., all the same. But remember, there's a greater incidence of chest pain presenting in the neck area, and as well as the jaw compared to male counterparts. So let's summarize the symptoms and similarities and differences between women and men regarding the presentation of coronary disease. Obviously, we can see the clinical presentation, as we've already said, is relatively similar between women and men, but women tend to have more fatigue, shortness of breath, and weakness than men as they're presenting complaints of a coronary event or coronary syndrome, if you will, and they have more neck and jaw pain. However, the most important clinical caveat to remember is not to ignore any symptoms of a life-threatening event, such as coronary disease or stroke presentation, etc. And it's underappreciated, especially in our female population. And we need to radically change that. Well, what can we do? Are there gender differences in prevention of coronary heart disease? We've already talked about its presentation, but what about prevention? And we're going to turn to treatment. There are no gender differences. Obviously, no smoking, maintain weight and weight reduction, regular exercise. We're going to talk about blood pressure, as you might imagine, as well as reducing cholesterol if there's dyslipidemia. So in that regard, in terms of prevention of the major risk factors for coronary heart disease, there are no gender differences in the approach to primary prevention of coronary heart disease. So what's the recommendations? And then what are some potential differences, however? There's no differences in the approach and probably the effect, the ameliorative effect, but there are still differences. Well, here's the American Heart Association recommendations for physical activity in both men and women. They don't define different gender differences. Aerobic exercise of moderate to vigorous activity, and you can see as well as I, the extent, the duration, and the frequency of those recommendations. However, this is interesting. We now understand that minutes count. It's time dependent as well as intensity dependent. So walking greater than 4 hours per week, and even if you do it in 10-minute intervals, is just as good. And that's a little bit of a difference, and I found that intriguing. Again, the recommendations, though, are similar for both females and males. However, the problem is our female patients just aren't doing it. Believe it or not, as much as our male population. So there are gender differences not in the recommendations or the prescription if you go for the exercise, but there's gender differences for how often females do it compared to males, and of course, this data shows that females exercise less often than males. And so that's an issue. So we can target prescription of exercise specifically to our female population, knowing the data here, as you can see from circulation, from our colleagues, shows that females participate in regular exercise far less than our male population, and regardless of ethnicity. Well, what about obesity? Is our female population more obese than our male population? And here you can see the rates of overweight and then definition defined obesity, as you can see, and we have one striking observation, and not unknown to us in South Carolina or in our contiguous and our neighboring states. Clearly, we have a significant population in our Black and African American population in terms of not only overweight propensity, but frank obesity compared to the Black male counterparts. Now here's where complications start to come in. There clearly are gender differences in hormonal patterns. Here's the life cycles of estrogen and testosterone, as you can tell through the ages, and we all know this. This is just for fun, just to put it on a chart and show us so we can talk about it a little bit. Clearly there's differences between the life cycle for estrogen versus testosterone in males. We've talked about the Women's Health Initiative over the last couple of days as it relates to all kinds of other things. Dr. Giesiak talked to us about calcium and vitamin D. This was obviously a landmark trial that really greatly changed our approach towards our female patient, or our female population, of a multitude of differing entities, including bone health and fracture risk, et cetera. And this is the cardiovascular components, as we all know. We know this data, that if you look, there were two components of the WHI. There was estrogen, progesterone, and estrogen alone, but both had significant surprises to them. The estrogen, progesterone component, of course, was stopped early after a mean duration of follow for 5.6 years versus placebo, because lots of not so good things happened, as you can see. It increased the risk of heart disease, increased the risk of strokes, clotting, breast cancer, while doing some good things, reducing the fracture risk and colon. But obviously the benefit did not outweigh the extraordinary risk. And of course, the recommendation was HRT for the primary prevention, if you will, not for menopausal symptoms, et cetera. We can talk about that some more. But for the primary prevention of coronary disease is obviously deleterious. In the general population, we'll talk about these specific subsets, but we know this data. And the same thing with the estrogen-only arm. Was progesterone the culprit, or was it just estrogen as well? And of course, we know the answer too. Estrogen replacement was associated with a mild reduction in heart disease, if you will, but significant increase in stroke, blood clots, no change in cancer. But again, there's benefit. Continue to show demonstration of fracture reduction, but obviously Dr. Giesiak's talk this morning showed us we have all kinds of better modalities, so this is not something we would entertain either. And the recommendations were then, of course, not to pursue such primary prevention, hormonal, whether estrogen alone or estrogen plus progesterone. However, if you further analyze the WHI, there was age differences between the groups. And I think that has some consolation for us, or consoling factors for us, if we're going to use it for other issues, such as perimenopausal symptoms, for instance. And it went something like this, as you know. If you're 50 to 59, there actually was a reduction in coronary heart disease risk and risk of stroke in the estrogen-only study. But as you became older, it changed. It changed actually to a an overall increase. And you can see the 9% reduction that we already quoted and the 39% increase in stroke. But if we're going to consider possibly estrogen for short-term therapy, for other reasons such as menopausal symptoms, mood disorder symptoms, etc., we have some consolation or some consoling in the fact that if we're going to use it in this age range, there actually was not a deleterious effect, but actually was probably favorable in the short term, but that's not why we would do it, not for coronary or stroke prevention. Well, what about oral versus transdermal approaches to estrogen? Again, for symptoms, not for primary prevention of coronary disease. It's interesting. The liver is an intense factory, as you know. Oral estrogen enters the portal circulation, goes right to the liver. A lot of bad things happen when estrogen sees the liver for the first time. Obviously, the liver has a large impact on not only estrogen metabolism, but metabolism in the liver in general. There's an increase in cytokine production, inflammatory markers known to be associated with coronary disease, clotting, etc. And there's an increased protection of LDL cholesterol, but most studies to date have shown that that doesn't have clinical significance to purposely lower and or raise, in this case, HDL. On the other hand, if you bypass the liver, many of these atherogenic changes, if you will, do not occur. So if we're going to entertain even short-term estrogen replacement for symptoms in our perimenopausal woman, perhaps, and this is not my area, I will defer to all the authorities that have already spoken over the weekend, including tomorrow. We may want to consider transdermal estrogen versus oral estrogen. However, we can discuss that further. It was just interesting to me that there's not only a delivery system difference, there's an actual inflammatory difference as well. So what are some caveats? Estrogen therapy may be considered for symptom relief if started early, but only for short term. Estrogen administered by the transdermal route may be more beneficial, or at least more gentle, if you will, on the cardiovascular system in general. But of course, the stigma is still there, and the recommendation is not for primary prevention of coronary disease. Well, what about antioxidants? You know, that's still big news. You know, what's the antioxidant of the day? Obviously, there was the primary prevention trial for vitamin E. You all know that this trial was negative. Every antioxidant trial so far has been negative, whether you be a male or a female, but particularly females, it just doesn't work. Vitamin E versus placebo, as long as 10 years. 600-ish deaths in the vitamin E group, 600 deaths in the placebo group, no significant difference. It was disappointing. We were all hopeful, of course. So what interventions have been shown to be ineffective? I just showed you the vitamin E data. I could have showed you data for all of these, but you can bypass them because they're all the same. No benefit for primary prevention, hormonal therapy, at least antioxidant supplements with vitamin E, C, and beta-carotene have been negative. Folic acid with or without B6 and B12 supplementation have also been negative. That's too bad, because that would sure be a simple fix. So now let's turn to blood pressure. Is there any difference in the presentation of blood pressure, et cetera, in our female population, our female patient? And the answer is yes, there is. Overall, if you look at large clinical trials and you look at females or males, there generally is no difference between the treatment response rates, pharmacologically, the lowering stroke, heart attacks, preserving the kidney, et cetera. But there are some caveats in there. We talked about yesterday, Monday in the sprint trial, that males seem to benefit greater than, obviously, the females in the sprint trial. Well, what about resistant hypertension? This is, I think, becoming increasingly our plague today. We have treated the simple patients with hypertension, the mild, the moderate, uncomplicated, low cardiovascular risk patients. In fact, in some countries such as Canada, it's even equivocal whether you treat low cardiovascular risk, mild hypertension from 140 to 160 systolics, if you will. On the other hand, what we're seeing more here in South Carolina, as we are seeing nationally, and now we're going to be seeing globally, now that we're actually getting out there, and we're determining prevalence rates of hypertension in various countries, in various parts of the world, that resistant hypertension, the prevalence is dramatically increasing. Part of that is we've treated the low-hanging fruit, the easy ones, and part of it is because the comorbidities, the co-risk factors are increasing, so particularly the obesity epidemic. as I showed you, more in females than in males. Well, what is resistant hypertension? Very quickly, you know the answer is mine. It's 3 or greater antihypertensive agents, appropriate classes that are complementary at appropriate doses. Resistant hypertension represents a treatment and control issue for 1 out of 10, but in some subset populations, probably even here in South Carolina, in our clinics in Columbia, just an hour and a half from here, we have a resistant hypertension clinic. It's probably 30 to 40% of our hypertensive population that we're now seeing in Columbia, but I do practice in a low socioeconomic and underserved clinical practice in terms of the general medicine. Our general medicine clinic, we were seeing so much resistant hypertension, we actually embedded we actually have we're now 2 years running as a solitary resistant hypertension clinic within the general internal medicine clinic to treat this subset of patients. Well, why do I even bring up resistant hypertension I wouldn't have done it if there weren't differences, but there are differences in the prevalence of resistant hypertension. Older age, as we're going to see, this is going to be a continuing theme. More obese, where I know there's more obesity in women than men, particularly in African American and Black Americans. High dietary salt ingestion, salt sensitivity, we're going to talk about a little bit. Diabetes, African American or Black race, and our female patient particularly. I was stunned when I first noticed, where are the guys in our resistant hypertension clinic? We have some. I would be silly if I didn't say we didn't, but they're predominantly female. And they're predominantly older, heavier, and of Black heritage. And residents in the Southeast United States. After all, this is the Southern Medical Association. This is an epidemic in the Southeast. So if we wanted to take a disease-specific approach in terms of our mission as the SMA, this would be a very, very good one to start. And of course, we're in the stroke belt. South Carolina is the buckle of the stroke belt as well. No coincidence. So what about lifestyles that contribute to resistant hypertension? Well, obesity, as already said, does. High sodium intake, physical inactivity. All three have greater prevalence in our female population than our male population. Unhealthy dietary patterns, heavy alcohol, that's going to probably be more men than women. But the big three are right there glaring at us. What about adherence? If you're going to detect them, you're going to study them, you're going to then have an appropriate pharmacologic and non-pharmacologic approach. What about adhering? I was stunned to find out that females actually adhere less than males. I've always thought it was the opposite, but actually that's not what the adherence data shows for hypertension. So what are some of the predictors of lower medication adherence? Oops. Again, our Black population, our female population, and, no surprise, obviously a lower SES group and or a federally funded clinic. I'm sure that Dr. Fliegen can tell us story after story after story of her experience, and I could bring you our experience from Columbia as well. But again, predominantly our female population and our African American population. So how can we approach this specifically with our female patient in mind? I'm a big proponent of combination therapy. I've come a long way. When I was in medical school, I trained at Penn State, and our director of clinical pharmacology was Art Hayes. He had just left the FDA as the commissioner of the FDA, and he's the one that taught me clinical pharmacology, specifically hypertension related. And he said, DiPette, you're not a doctor if you use 2 drugs at the same time. And if you, matter of fact, you're not only a doctor, you're below whatever, or you're a healthcare provider, especially if you use them in fixed doses. If you ever did, my God, I'll throw you out. I'm not going to let you graduate. We've come a long way. That is absolutely wrong, and I'm going to tell you why. What's actually interesting is it's not even new, because the very first study that demonstrated that reducing blood pressure decreases morbidity and mortality was done in our VA centers in the 1960s, the VA cooperative study. The VA cooperative study, I wish I had known this when Dr. Hayes was yelling at me, because I was saying, what about the VA cooperative study? The VA cooperative study used fixed dose treatment, combination therapy. They used the thiazide, the serpine, and hydralazine in 1 pill. So they used 3 drugs, fixed doses. And it was called Serapis at the time. And what did it do? It dramatically reduced heart attacks, strokes, heart failure, etc. So it's not even new. So our very, very first study with evidence-based medicine that used fixed dose combinations. This is a review from Dr. Madison in 1990, but the study was done in the 1960s, published in 1969. That's when I got acquainted with Bob Dylan. But JNC7 even recommends 2 drugs. It's buried under, page whatever, 47 or 63, I don't know. But actually, JNC7 recommends consider initiating therapy with 2 drugs whose blood pressure is 20/10 millimeters of mercury above the goal. More than 2/3 of it is right out of JNC7, or this is Dr. Trevanian, my mentor. More than 2/3 of patients will require 2 drugs anyway. So why not consider starting with 2 drugs? And why not even consider starting with combinations of drugs where it makes sense, whether it's singly together and or in a fixed dose combination. I'm going to show you some dramatic data that we're already starting to put in effect globally that we're not doing in the United States. I'll show you some interesting data. So what are the advantages of initial combination therapy? Remember, we're always coming back to the female patient, which has less adherence than our male hypertensive individuals. Well, most are going to need multiple drugs. Our female population has more resistant hypertension than our male population, and just by definition, they need 3, and they need 1 more after the 3 because they're still resistant. So they need 4, or 5, or 6. It may allow lower doses of each of the 2 drugs, which actually might reduce side effects. So as we're going to see now, they do. Simplified regimens has been documented to increase adherence. That's common sense, it's intuitive. Right? It addresses the effects of clinical inertia, and I'm going to really harp on clinical inertia, particularly with our female population. In about 3 slides, we're going to get pummeled by clinical inertia. And it has economic benefits. Their use clearly lowers healthcare costs. There's initial pharmacologic costs that go up, but because they have fewer office visits and better control, the overall economic cost benefit is extraordinarily favorable. In fact, we're trying to convince some health ministries in Columbia, the country Columbia, not the city of Columbia. There's actually a legislative law not allowing fixed dose combinations in the whole country of Columbia. I met an hour with the health minister in Bogota 3 months ago, begging and pleading, can we visit that, et cetera. But that's the resistance. And now I know where that's coming from because Art Hayes must have taught him too. So does it mitigate the side effects? And the answer is yes. Once you use a RAS inhibitor, be it an ACE inhibitor or an ARB, that stands for reangiotensin aldosterone system inhibition, and the 2 we use, of course, are ACE inhibition and ARBs, no difference between the 2. The direct renin inhibitors would be a 3rd class. We just don't use them because there's not much benefit. There's no difference. But they blunt the side effects of diuretics. So if you're going to use a RAS inhibitor and a diuretic in combination, it's perfect because the RAS inhibition blocks the activation of the sympathetic nervous system that occurs with diuretic therapy because it blocks norepinephrine release. It blunts the hypokalemia because it blocks aldosterone. It blunts the hyperglycemia that's associated with thiazides. Doesn't eliminate it, but mitigates it, blunts it, and it blunts the hyperuricemia as well. And if you use losartan, one of the ARBs that's a uricose-uric, just because it's unusual, it's the only one that does that, you don't get the hyperuricemia at all, especially in your gout patient. Well, what about calcium channel blockers, the other common class that we're using? RAS inhibition blunts the major side effects of calcium channel blockers as well. So both an ACE inhibitor and ARB will blunt the effects of the dihydropyridine calcium channel blockers. Again, it'll blunt the activation of the sympathetic nervous system. It'll blunt the heart rate increase to amlodipine or nifedipine or any of the pines, if you will. And it also blunts the pedal edema because it vasodilates the vein, whereas the calcium channel blockers only vasodilate the arterial. So the arterial pressure is translated to the capillary bed, and it physiologically exudes fluid into the legs. It's physiologic, it's not pathologic, but if you dilate the vein, you reduce the capillary pressure in the pedal beds, and you get less of the edema, if at all. So it makes sense from the side effect pharmacologic profile. But more importantly, this is the issue. This is the major issue that we're finding as we go out and look at why patients are not controlled, particularly in the United States. But I bet we're going to get there when we actually have a more robust global program as well. We're going to have some low-hanging fruit globally, and then we're going to run into this, clinical inertia. This is probably the major reason why hypertensive patients are not controlled. Whatever you want to define control rates are, let's just say 140 over 90. So what is clinical inertia? Clinical inertia is on us. It's our role, it's our burden, if you will. This is a very interesting study, and it's a human nature study, if nothing else. What this says is that this is the percentage of visits without a medication intensification. In other words, you come to the patient comes to the physician's office or the healthcare provider's office with a high blood pressure. And this is the number of percentage visits they leave without a medication change. A dosage increase or an addition, anything that changes the pharmacologic therapy of that blood pressure elevation. If you walk into the office, and watch this, I can't wait for you guys and gals to go back and look at this. I'm just so excited. I'm just beside myself. If the patient comes in with a blood pressure systolic greater than 180, 55% leave without any medication change addressing the systolic blood pressure. That means 45% give you a change in the pharmacologic regimen, whether it's a dosage increase or an addition of another drug. But look at what happens when you come in with lower blood pressure, but still hypertension. 72% leave without a medication change if they're in the 170s, 79% if they're in the 160s, and a whopping almost 90% of patients leave that office visit without changing the antihypertensive regimen, yet they're hypertensive. This isn't even 140 over 90. If we did 140 to 149, it would probably be 100%. Why? We make excuses. They ran in, they were excited, they were stressed, it's hot, it's any excuse, and it's human. We're not bad dogs. There's an interesting book. There are no bad dogs, just bad dog owners. Well, we're not bad dog owners. It's just our own human nature. We need to address this, and we need to address this fast. These individuals need changes, and they need changes in their pharmacologic regimen more rapidly. And this is our South Carolina data. This was noticed by my colleagues from NUSC, just up the road, in Charleston, literally up, so it's a little bit north, that did a very, very interesting study. They noticed this in South Carolina. And they were doing it because of the buckle of the stroke belt. We were interested in, obviously, the tremendous stroke rate. And what can we do to mitigate the stroke rate in South Carolina? If you had to pick one thing, lower the blood pressure. There's many other reasons, of course, but lower the blood pressure. So what's clinical inertia? Clinical inertia, again, is not intensifying that antihypertensive regimen. And these are control rates. Here's the systolic blood pressure and diastolic blood pressure. Now, these are clinics across South Carolina that gave us data. They would just feed us data on every visit, on every patient. And my colleagues could just collect this data. Here's the systolic blood pressure. If the visit had therapeutic inertia, meaning there was no adjustment, they had hypertension in that visit, an elevated blood pressure, and there was no medication change, their average systolic blood pressure was about 140. If they had a medication change, meaning there wasn't therapeutic inertia, the systolic blood pressure of that group was 125. Now, who in the world wouldn't think that that makes a difference? If you have, in terms of 13 millimeters of mercury. And diastolic the same, about 4 millimeters of mercury. And here's the control rates. Those that had their visits with therapeutic inertia, meaning no adjustment of medications, when they had a high blood pressure, the control rate was only 45%. If we looked at the group that had medication adjustments, it was almost 80%. Well, the control rate in the United States is 55% right now. We are not doing a very, very good job. And probably one of the most significant reasons is therapeutic inertia. We have to be adjusting and increasing blood pressures more forcefully, more aggressively, and more frequently. That leaves us with salt. And it always ends, it starts and ends with salt. It's amazing that sodium restriction or salt moderation was advocated in the early 1900s. Duke popularized the rice diet, our colleagues at Duke. Well, the problem with that was it was an inpatient regimen for months as they desalted you, if you will, with success, with blood pressure reduction, etc. The rice diet was popularized by our Duke colleagues in 1940. Obviously, it was too intensive and too cumbersome, wasn't done. So then it led to public health recommendations. And the two public health recommendations are, there are general recommendations for salt moderation and restriction from the Institute of Medicine and the American Heart Association. They differ. One's, the AHA is 1,500 milligrams a day of sodium. The Institute of Medicine is 2,300, but I don't care what it is. They're recommendations. What's our average salt intake in the United States? It's probably 6 to 7 grams. In my clinic, it's probably 13 grams of sodium, and we measured it. And it's amazing, especially again in our cultures. So why is sodium, not only is sodium as a risk factor, but if there's a pathophysiologic reason to consider the role of sodium as it relates to raising blood pressure. And this is a physiology or a pathophysiology, if you will, I want you to bring home. That hypertensives divide, like the Red Sea, into salt-sensitive individuals and salt-resistant individuals. So what do I mean by that? Salt-sensitive individuals mean that when you eat a dietary sodium load, your blood pressure rises. Salt-resistant individuals, when you eat that same dietary sodium load, your blood pressure does not go up. That doesn't mean sodium's benign. It just means that it's not raising your blood pressure. It may have other inflammatory effects, cardiac effects, independent of blood pressure. And this is an example of salt sensitivity. These are individuals, and this is a 24-hour ambulatory blood pressure. And here's when they're on a low sodium diet. You can see their systolic blood pressure is 130. Diastolic blood pressures maybe mid-70s. They dip, they go down at night, which is normal. So they have a dipping pattern. When you put them on a high sodium diet, look where their blood pressure goes. These are salt-sensitive individuals. Their blood pressure skyrockets up to even 150s to 160s, goes down at night. Diastolic blood pressure now goes into the high 80s and goes down at night. But even the nocturnal blood pressures are significantly higher on a high salt diet versus a low salt diet. That's salt sensitivity. That's bad. Can you imagine the pressure load? If we integrated these curves, the pressure load difference for not only a day, but a week, a month, a year, a lifetime, those millimeters of mercury would be in the billions higher. That can't be good. And this is the Japanese have proven it. This is now mortality data, long-term mortality data. They follow people that were salt sensitive, meaning their blood pressure goes up when you eat a sodium load, and salt-resistant individuals, meaning your blood pressure doesn't change when you eat a sodium load, in terms of mortality and/or present free of events, cardiovascular events, and you don't have to need statistics. This is kind of like for fun. All you have to do is look at these curves and say, there's something wrong. These are the salt-resistant individuals, so they're relatively free of cardiovascular events. This is the salt-sensitive group, and they're dropping like flies. So in about 10 years, they have about a 40% incidence of cardiovascular events, as you can see. So significant event rates and mortality follows. So how does this all revolve back to the female patient? Well, it's the constellation of those risk factors that we've already been talking about that are more prominent in our female population. If you wanted to just in your clinic try to decide who's salt sensitive and who's resistant, you can do it with some degree with demographics, and it goes something like this. Salt-resistant individuals are younger, they're male, they're lean, and they're predominantly European Caucasian or white. If I were a little younger, I would be absolutely the poster child for salt resistance, meaning I would bet that if I ate a sodium load, my blood pressure wouldn't go up. Now that would still be bad for me for other reasons, but it wouldn't raise my blood pressure. On the other hand, it's the same group. The older you are, the more female you are, the more obese you are, and obviously your Afro heritage strongly predicts salt sensitivity. So if you're going to harp on sodium moderation, sodium restriction for blood pressure, not just good health, Pick the female patient. Pick the female hypertensive patient. And obviously, if they have more of the demographics, it's even, this is probably 90% salt sensitive if you have all four, and 90% salt resistant if you have all four. It divides with reasonable certainty. There's always gray zones. You know, what if you're 50? Well, you're half male and half female. I don't know about that. But you're in the middle, you know, who knows? But these are pretty good guides. So what about medications now? Let's get back to combination therapy, clinical inertia, and salt sensitivity and salt resistance. Salt sensitive patients respond better to diuretics or calcium channel blockers. Their blood pressure will go down to a greater extent with single agents if you use a CCD or a thiazide diuretic. Salt-resistant individuals' blood pressure will go down to a greater extent with a RAS inhibitor, an ACE inhibitor, or an ARB. But who cares? Once you put these together, once you combine an ACE inhibitor with a diuretic, or you combine an ACE inhibitor and a calcium channel blocker, you get both worlds. You capture the salt-sensitive individual, and you capture the salt-resistant individual, and once you're on both medications, the blood pressure goes down the same with those two medications, whether you're salt-resistant or salt-sensitive. Another very, very strong reason why to use combination therapy. Beta blockers would be included in the salt-resistant regimen, but of course we don't advocate for beta blockers unless there's a compelling indication, because there's really good data showing they do not decrease stroke as single agents in hypertension. Be you a female or a male, they increase stroke in smokers. So this is a model for you to bring home. It may not be my model. I may want to tweak it around, etc. But because of the Global Heart Initiative, one of the challenges that I was given on the leadership team was to develop not only core sets of medications that we're going to now use globally, the core classes and a primary and secondary drug within those classes, but the algorithm to treat hypertensives in low to middle income countries. And it actually applies probably even to a greater extent to high income countries as well. This is from my colleagues at Kaiser Permanente, that I've become very, very close to over the last 2.5 years, because Mark Jaffe, who leads this, and Norm Campbell from Canada, we're the three that are leading the Global Hypertension Initiative, independent of the CDC and the World Health Organization. This is what they do at Kaiser Permanente, and it's been absolutely dramatic. The results have been published in the New England Journal of Medicine, JAMA, and as well as, what's the other New England Journal of Medicine, where else did they publish it? I can't remember. In any event, those two. So what do they do in Kaiser Permanente? They start with two drugs in every body, in every hypertensive individual. As you can see, here's anybody that has a greater than 140 over 90. Now, this is not the exceptions, you know, this is the standard patient. This isn't somebody that has complications. So if you have a blood pressure of 140 over 90, and you come to the clinic in Kaiser Permanente, this is what you get. There's no ifs, ands, or buts. Remember, it's an HMO, so it's free. All the medications are free to the patients. You get they only use one dose of the medicine, 20 milligrams of lisinopril and 25 milligrams of hydrochlorothiazide. So they use one dose combination, fixed combination. You get half a tablet on the first visit. So you're getting 10 and 12 and a half. If your blood pressure is still elevated a month later, you go to a full tablet. 30 days later, if your blood pressure is still elevated, you get 2. So you get 40 and 50, 40 milligram total dose of lisinopril and 50 milligrams of hydrochlorothiazide. If you're still elevated, you get amlodipine, 5. And if you're still elevated, you get 10. And then if you're still elevated, you get spironolactone. They've taken away the beta blocker. You now get a tenolol. And they do this religiously. It doesn't matter if you ran in from work, if you drove, if you walked, if it was hot or if it was cold. Their control rates for Kaiser Permanente went from 60% to 92%. Their control rates are actually scary. Because in fact, their blood pressures are rather low. The whole blood pressure in the Kaiser Permanente group is 127 over about 76, if I remember. And the outcomes now have dramatically declined. And they published the outcomes in the New England Journal of Medicine to this program. And it shows that it doesn't matter who you are. Once you use that combination of a RAS inhibitor, in this case a thiazide, But you could use a RAS inhibitor and a CCB. I might prefer that, but there's not an easy combination. They want that simplicity as well. It doesn't matter who you are. If you're pink, blue, black, white, male, female, etc. Here's the data. These are the control rates. And now there are 4 million people in this system. This isn't a small clinic of 10 people. This is 4 million people. Blood pressure control rates are approaching 90%. If you're not Hispanic, white. If you're Hispanic, if you are African American or black, if you're Asian Pacific, they're in California, they have a significant Asian Pacific population, and anybody else, if they can't tell who you are. There is no difference in these control rates once you use the RAS inhibitor and the thiazide together, and you defy clinical inertia, and you do a stepwise algorithm increase. So in summary, cardiovascular disease is the leading cause. Hypertension is the leading cause of cardiovascular disease, now particularly in women. 50% of cardiovascular risk can be avoided by lifestyle modification. Women are at higher risk if they have diabetes. Gender-specific risks include menopause, oral contraceptives, and hormone replacement, as we've been discussing over the course of the last few days. The diagnosis of cardiovascular disease in women is underappreciated. Even though it doesn't present particularly different, it's still underappreciated. Coronary disease is accompanied by atypical symptoms such as shortness of breath and fatigue, and jaw and neck location, if you will, more embellished. So what do we conclude? Prevention, diagnosis, and proper treatment of cardiovascular disease and hypertension is crucial. Most cardiovascular risk factors are the same in men and women, with the exception of, obviously, reproductive hormone differences. The role of the clinical therapeutic initiative and adherence is primarily responsible for undertreatment, particularly in women, because we're not appreciating the cardiovascular consequences as great in women versus men. Strongly consider starting or initiating treatment algorithms that are simplified, that are regimented, and that are implemented, particularly the use of fixed dose combinations. We have now taken this program to places that you wouldn't believe. Barbados was our first demonstration project. Control rates went up within 1 year in Barbados. We expected that. That's not a low-income country in the Caribbean. But then we went to Chile, then we went to Colombia, and then we went to Cuba. And in fact, Cuba was doing the best of all the Latin American countries. They had a control rate of 36%. It's already up. It's almost all the way up to 72% in only 18 months. This can be done. The salvage will be dramatic, and we ought to start in the United States, in addition to obviously rolling this out globally. Question: what is this? I showed this to my medical students in clinical pharmacology, and they said it was a space transporter. EKG. It's the first EKG. Imagine if you're a poor medical student, there was no informed consent, IRBs, nothings, and they tell you as the middle, dude, just sit right here. John, come over here. Sit here. By the way, put your hands in these 2 buckets of water. And there's some ions in there. There's some of these ions floating around in there. And I'm going to pull the switch, which is what he did. Look at this. That's kind of scary. It's a good thing electricity is going this way and not that way, right? That's the first EKG. Now they're on our iPhones, right? They're probably going to even be that big if we didn't have all the other stuff on the iPhone. So questions. Okay, question 1. Cardiovascular disease in women occurs only after 65. No. It's a continuum, remember? More recent paradigm. Only 2 years after menopause? No. Throughout the journey of life? Absolutely. And similar to men? Yes, with those exceptions. That could have been an answer, but the better answer is throughout the continuum. There's a better answer versus D could also have been correct largely, but there are some differences as we talked about. Good job, everyone. Question 2. Following statement about cardiovascular risk factors in women is true. Only diabetes is important. Are similar? Yes. Except for menopause and progesterone, and the other 2, of course, are incorrect. Only menopause is important. Great job. Question 3, the Women's Health Initiative showed that estrogen plus progesterone increased heart rate? No. Increased stroke? Yeah, kind of. Increased blood clots? Yeah, but all the above. Yes. The following statement is true regarding acute coronary symptoms in women. Chest pain is absent? No, in fact, it's very similar to men. Right? In addition to chest pain, fatigue, shortness of breath, and weakness may be present. Yes, they're statistically different, and all the rest, of course, are not the best answer. And question 5, last but not least, in women, the leading cause of death is coronary disease. Stroke's not far behind. Thank you very, very much for having me, and I look forward to continuing our conversations, not only throughout the day, but specifically tomorrow as well. Again, thanks for having me.
Questions from the audience?
Thank you.
Enjoyed your talk there.
Thank you.
Very much. My question was about your Kaiser Permanente study that you referenced. Were there any tricks that they used to get compliance rates higher than what you might see in other clinics?
Yes. First of all, they are firm believers in giving data back to the clinicians, no matter who you are. So this data was presented back, and they showed consistent graphs as the program was initiated. Also, the tricks were integrated team approach of care. Very key. Nurses can make decision making. Pharmacists are leaders in many of the different clinics. And the different clinics develop their own way to govern because it's such a huge system. But the commonalities are simplicity, ease, consistency, implementation, and then team, integrated team care.
Did the pharmacist make sure, call patients that they were taking their medication?
Yeah, it was actually the opposite. If they saw blood pressure that was elevated, the pharmacist or the nurse or whomever they charge with that role calls the patient and increases the dose.
I see. Thank you.
Yes, that was an excellent question. Other question I get as a frequent FAQ is, well, their population, again, it's clinical inertia, right? We want to try to find the reason it's different than us. Because even in my institution, if I showed that data, which I have, the first question I'll get is, they're not the same population, Dr. DiPette. They have, they're an HMO, they're healthy, they're young, they're all these people running in Seattle. It wouldn't work here in Columbia, where we have lower income, obese, differing genders and racial differences. No, then I showed them the data. I let them ask that question first. I go, I'm glad you asked that question, because here's their data. It doesn't matter. Yes?
As part of the Kaiser study, did they standardize lab draws also, looking for electrolyte abnormalities? Is that protocolized too?
I'm not as familiar, I have to admit, I'm not as familiar with that, but I do believe they do electrolyte prior, and then at 1 month. But then after that, if you're normal, I don't know how often then they repeat like a electrolytes, BUN, creatinine, microalbumin, etc. I just don't know I don't know the definitive answer, but that's not as important to the program. Matter of fact, they would argue less is better. Anything that simplifies the approach that makes clinical sense, of course, in standard practice, they would say simplicity number 1, standardization number 2.
Do you see a difference between the auscultatory blood pressure and the automated blood pressure?
Absolutely. Yeah.
Okay, which one are you?
Well, we have now transitioned to only oscillometric automated blood pressures in our clinics. I'm not sure that that's the difference between oscillatory and automated is that great. But what I do believe is that the variability will be less with the oscillometric automated machine approach to taking the blood pressure, even with the nurse present in the room, which is what we still do. I'm trying to get the nurse out of the room, or me out of the room. The last person that should take a blood pressure is a doctor or any clinician, any practicing clinician. We almost should never take a blood, unless it's an emergency. So I don't think there's a difference in the level of blood pressure between the two, but I think that you will decrease the variability of the blood pressure. And it certainly decreases the training necessary, so it saves time on the front end, but the argument will be, well, it takes more time on the back end. But now with non-observed
automated oscillometric, then the blood pressures are actually lower. And that's the data that I showed you from this spring trial.
After the re-adjudication of the Women's Health Initiative, in your talk you said that if the blood pressures were in the women between 50 and 59, there was a decreased risk in cardiovascular disease.
Yeah, for primary prevention, nothing to do with blood pressure.
Okay, primary prevention, yes. But so my question is, if the woman was started on her hormonal therapy between 50 and 59 and continued,
you're asking, yeah.
Would she then fall into the 60 to 69 group, or would she stay in the 50 to 59? We
don't know. And that's why they recommend it. There's far better ways to prevent coronary disease now than estrogen replacement anyway, which is the good news. So I think the recommendation, since we have so many other modalities that are probably more potent and more efficacious with safety data, that just don't do it. But the question I get all the time, especially from my OB/GYN colleagues, by the way, our OB/GYN clinic is just right up one floor above ours, and they're at the same time. That floor is like they're right in my office. I mean, it's amazingly, and that's wonderful because it's a team approach. The question I get is, oh, what about the menopausal symptoms or short-term bone stabilization? And again, this is not my field, so I will defer to my OB/GYN colleagues. But when I look at the data and what we would do and what we would say, and I've heard other speakers also say the same thing, that short-term estrogen replacement for specific targeted symptoms and or purposes other than cardiovascular prevention in the perimenopausal, those age ranges is probably okay. But I will defer to my OB/GYN colleagues to challenge that, and I'd be prepared to listen. Okay, there's some from the. What do you recommend when the patient's blood pressure is high in the office, but home readings are low normal? And how often do you see that? What they're talking about is white coat hypertension, where your blood pressure is high in the office, but actually low at home. Or if you do a 24-hour ambulatory blood pressure and it's low, I mean it's within the optimal range, if you will. The first caveat is all blood pressures will be lower if you take them out of the office, at home versus in the office. That's the number one, and or by ambulatory blood pressure monitoring. So you have to use a different criteria. You can't use 140/90 if you're being guided by home blood pressures. It's 135/85 at home. So that's the diagnosis of hypertension if you're using home blood pressures. But if you've got rock normal home blood pressures, 120/80, 125/over 82, or 75, that's white coat hypertension. I don't treat that. But what I would do though is I would just make sure I look at the eye grounds, one more time, or an ophthalmologist, appropriately with all that fancy gizmos, which I'm jealous of, and really, really see the eye, and or listen to the heart. There's no S4. There's no other cardiovascular symptoms and or signs. Then that's white coat hypertension, and you don't treat that blood pressure. That's that high blood pressure in the office, but you follow them. So that would be the current recommendation. There's also masked hypertension, which is the opposite. They're normal in the office and they're high at home. That's serious. That's just as significant as hypertension. If they had hypertension in the office, that's called masked hypertension. And the only reason we're finding that now is we're taking home blood pressures more. And people are taking their blood pressures more. So that's masked hypertension. That has consequences. You treat the home blood pressure if the home blood pressure is elevated. And yet, even if it's normal in the office. Okay, the second question from the web is, did you say that a atenolol beta blocker arm was discontinued? No, there was no. First of all, just for assuming, there was no beta blocker arm that was discontinued in atenolol. That wasn't part of the study. What I said was, though, that the older evidence-based medicine, with the older beta blockers, which would be atenolol, propranolol, etc., there's significant evidence that while they lower the blood pressure, they may not reduce stroke to the exact same rate as you would predict by the blood pressure reduction. And that evidence is probably good enough for our guidelines committee, which now, of course, you all know, do not recommend beta blockers for first, second, third, or even fourth line therapy. They're still used for compelling indications: migraines, heart failure, coronary artery disease, of course, incontinent. and hyperthyroidism, while you're getting the hyperthyroidism under control. That would be more short-term. But even I'm talking about even chronic beta blocker therapy. So the good news is we have new classes of antihypertensive agents. Now the question I don't know the answer to though is what about the newer ones? The newer beta blockers are vasodilators as well, like carvedilol, even the older labetalol, Nebetalol, was an NO. It's an NO donor as well. We just don't have any data. So right now, I would stick with the guidelines. Your, CCB, first-line therapy, CCB, thiazide, or RAS inhibitor, and then combination of either of those two groups. Add the third one, and then add spironolactone.
Patients bring in their blood pressure cuff to check accuracy by comparing.
Yeah, very, very good question. I shouldn't even have mentioned it. Anytime you mention the word home blood pressure monitoring, you must have the patient or the individual bring their blood pressure cuff into the office, at least to get it validated once. Now, they're pretty darn good. And if you look, there's now a seal on the blood pressure machines that they're certified, at least at the methodology, et cetera, that they're using. And there's a certification. There are various different companies, but you'll see it on the box. But even then, still have them bring it in because it's a machine like anything else. First of all, you can also see are they taking it right, and you can teach them how to take their blood pressure, and up north they're probably taking it over the parka, and the North Face, no, so it gives you an opportunity to teach the patient, check the machine to make sure that it's, it's compatible with your oscillometric machine or your oscillatory if you're doing oscillatory methodology. And then, of course, even if they want to bring it back yearly, that's fine. If they buy a new one or change or lose, bring the new one in. Anything that gets you and the patient or the team and the patient, whether it's the pharmacist or the nurse or the clinician, together is a good thing. It's a teachable moment, if you will.
Concerned about diuretics in elderly study.
Yeah. The question is there a concern about diuretics in the elderly? Studies include older than 80. And the answer is that's what our studies actually use. All of our standard studies like the SHUT trial, the systolic hypertension in the elderly program, the European trial in the same population, in our over 60 systolic hypertensive individuals use thiazide-based treatment. Like anything else, though, you've got to be careful. Any medication can lower the blood pressure too much in our elderly. There's hyponatremia in a very few. There's a syndrome of reset osmostats in our elderly individuals that they'll become hyponatremic on a thiazide diuretic. It's infrequent, but it happens, etc. The very elderly trial, it's called the HIVET, hypertension in the very elderly trial, was greater than 80 years of age. They used ACE inhibitor-based therapy. I believe they added on a diuretic if they still needed control of that study. But I don't think the agent matters as much as the clinician and the individual talking together, going over what could be very, very good, and then what obviously to look for. And in the SPRINT trial, of course, we used intensive diuretics to get that blood pressure down to 120/80, in addition to other agents. And of course, you saw the data. The data is what it is. The benefit far outweighed the side effects, but there were falls, and there was hypotension, and there was hypokemia, for sure. Nothing's free. Are there more? What? Okay. What about? This is a very, very good question. What about hydralazine, and when should you use it? First of all, hydralazine is a good drug. There's a couple issues though with hydralazine. Why isn't it on that? There's good reason it's not on the algorithm, because we have other agents. Because you can say the same thing. What about clonidine? What about some catalytics? They're not on there either, because there's less evidence-based medicine with those agents. But let's talk about hydralazine specifically. First of all, it requires multi-daily dosing, which significantly impact adherence. So you have to give it at least twice a day. Probably, actually recommended 4 times a day. So that's not going to work today, nor do we need it, because we have so many once-a-day classes that are safe, efficacious, etc. But the other problem with hydralazine is that it's a pharmacokinetic, it's a pharmacogenomic difference. Half of us, we would split like the Red Sea in this, but there's no demographics to predict it. This half would be slow acetylators, So the hydralazine is metabolized by acetylation in the liver. There's a genotype that slowly acetylates and inactivates hydralazine. This half would be fast acetylators. That means you acetylate the hydralazine very, very fast, and you rapidly inactivate it. And you can't tell who's whom. So in the slow acetylators, the hydralazine dose will build up, and it will be efficacious, and it'll lower the blood pressure. In the fast acetylators, you can give as much hydralazine as you want, except for very, very high doses, which we wouldn't use because of lupus-like syndromes. And it wouldn't work, so it would just be rapidly chewed up as it goes from the GI tract into the portal circulation and into the liver. So that's another reason to stay away from hydralazine. However, my nephrology colleagues absolutely have to use hydralazine as a 6th drug, or the 7th drug in some very, very difficult times, or minoxidil, if you will. But that's where they're reserved for, including clonidine. Clonidine is a very, very useful antihypertensive agent. It's just not one I would recommend choosing as the first 4. But we use a lot of clonidine in my clinic, in our resistant hypertension clinic, because we need a 5th drug. And they have renal insufficiency and renal failure, and they're sympathetically driven, so you need a sympatholytic. But these are individuals that are for me, or for the, for a resistant hypertension clinic, et cetera. So clearly, that's where you would use those agents. The hydralazines, the sympatholytics, the minoxidils of the world. Yes?
One more question.
I'm here.
What about nighttime dosing?
Yes.
Splitting up some medicine morning, some
This is really interesting, and I can't tell you I understand it, but the data is the data. What about giving a dose of an antihypertensive agent at night? Now, theoretically, intuitively, you say, well, why would I do that? Because it might make that nighttime blood pressure even lower. Because remember, the blood pressure in the individuals with low risk dips at night. If you're non-dippers, that's bad. That's an increased cardiovascular risk. So intuitively, I would have said no. Why would you do that? Give it all in the morning. However, there's been several studies, one specifically from Spain, that demonstrated that when you're up to 3 drugs, give one of the drugs at night versus all of them at once in the day, and the blood pressure was significantly lower by just simply not changing anything else, just simply changing the once-a-day dosing to before bedtime. And so I would recommend giving it a shot. I think it was the CCD. I don't remember if it mattered which one it was, because they were going to be on a CCD, a thiazide diuretic, and a RAS inhibitor at that stage anyway. So try one at night, giving one at night.
So do your lisinopril HCTs in the morning.
And maybe the CCD at night.
And CCD at night, okay.
Yeah. Now this is all a little less evidence-based, but the data's significant. What I've also done is divided up the lisinopril BID. Kaiser Permanente gives that higher dose lisinopril, 1 pill in the morning and 1 pill at night. And actually that could be more efficacious too. And I've noticed that in our clinics.
We have time.
Well, I'll be happy to entertain any of them. Oh, there's another one.
Sorry.
More the merrier. I mean, that's what we're here for, right? Aren't we here to just talk and discuss and interact and go to the beach?
Yes.
Was there any data, or did Kaiser have an option for people who had ACE allergies or angioedema?
Of course.
Was there an automatic ARB that they used?
Of course. Yeah, and pregnancy. You would never use ACE inhibition in a reproductive. This is female condom.
Sure.
So yes, they would use the ARB.
Was there a specific one they used? Like if I go home and print out this guideline and post it up in my cubicle. I didn't see it.
Well, I did it quick. Right? Let's see if it's not good. If pregnant, no, they only do it for pregnancy. They didn't have it. They may have it in their algorithm online, but they have the pregnancy potential. Obviously, just use the thiazide, then go to the CCD and spironolactone, because you would not use a RAS inhibitor. But it doesn't. I don't see it on that one regarding just cough or more importantly, angioedema. But you can use the ARBs for sure. Again, thank you very, very much for having me.